As a surgeon, at times I hate these kind of patients. And these are the patients who keep on waiting for their cataracts to get dense and mature and resultantly very difficult to operate safely. So this is one patient who had a mature cataract, a very non-responsive pupil and a hard cataract. Now this is the B scan which shows a nearly normal posterior segment, and this is the surgery which has been initiated, and we can see the pupil is not very well dilated. It is hardly 6 millimeters in size. The capsule has been stained, and we are proceeding for capsular excess. The problem with these kind of cataracts is as the age advances, the cataract gets bulkier, the nucleus gets more compact and leathery, and at the same time the capsule and the zonules, they start getting weak and fragile. So this becomes a recipe for a disaster. And as a surgeon, I am there to provide the relief to the patient from these cataracts so that they can see well. And as we can see that these all features make this surgery more risky in terms of preservation of capsule and compromise of the corneal endothelium. So now we'll go for a direct horizontal chop using the burst mode, which provides a nice crisp and a definite shot of power at the start so that we have a good purchase, and we have 2 or 3 bursts, and then we have a direct horizontal chop which is completed. And then we rotate the nucleus, and you will notice that I will do more than 4 quadrants, and this is very important because if you bisect and trisect and dissect this nucleus into more than 4, rather I will dissect it more than 6 pieces, and that will make these pieces smaller and more manageable. However, the posterior plate, which is really difficult to get in these cataracts, the reason being that one doesn't want to stretch the separating forces between the pieces too much, because one is also afraid that the capsule may give way at place. So once these pieces, they are not separated clearly, especially at the posterior pole, that may actually result into a definite posterior plate which will keep on amalgamating these all individual pieces, and that will be a problem because ultimately the posterior plate is lying on the posterior capsule, which is very difficult and risky area to reach up to. And see here, this is the problem. The posterior plate is not allowing the pieces to come up, and I am afraid to go ahead and fetch the posterior plate at the center. So somehow grabbing the peripheral parts, the pieces have been emulsified and we have removed whole of the nucleus. But believe me, this was a difficult surgery, and one has the adrenaline and heartbeat going up all the time in the fear that there may be a tear in the capsule and a good surgery may have a compromised outcome. The IOL has been implanted and it is being dialed into place. So we can appreciate the pupil is not very large, but still the surgery has been done and the anterior chamber has been washed, which the part has been edited out, and the chamber is formed. This is the next day post-op picture, which is showing a very clear cornea and a good surgical outcome, and this is the day 7 picture, which is showing the final picture at the time of refraction. Thank you.